Good afternoon and welcome to today's OR Today webinar, Endoscope Reprocessing, Why the Critical Steps are Critical. Today we are joined by Robert Dybec, OR Nurse Manager at NYU Long Island Hospital in New York and consultant to Ruhof. OR Today's webinars would like to thank today's sponsor, Ruhof. Ruhof is an innovator and leading manufacturer world-renowned for offering reliable solutions and individualized service to help you meet and exceed your decontamination and materials management challenges. Ruhof not only provides the most effective decontamination products on the market, they also allow healthcare professionals to verify effectiveness with the Ruhof ATP Complete Contamination Monitoring System. ATP Complete is a reliable method for verifying the cleanliness of all hospital services, scopes, instruments, and hand hygiene, with results in only 15 seconds. Ruhof has a knowledgeable and responsive customer service department, as well as a seasoned sales team ready to help their customers find the best cleaning solution for their facilities. For more information, please visit ruhof.com. Today's webinar is eligible for one continuing education hour. You can obtain your certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1CE certificate, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. We'll have a live Q&A at the end of today's presentation, so please submit your questions anytime using the questions feature on your webinar dashboard. Okay, let's kick off today's webinar by giving away one of our brand new OR Today Live lunch bags to the attendee that can tell me the answer to the following trivia question. Which city hosts the Macy's Thanksgiving Parade? Answer now using the question feature on your dashboard, and I'll reveal the answer at the end of the webinar. As I mentioned earlier, our presenter today is Robert Dybec, OR Nurse Manager at NYU Long Island Hospital in New York and consultant to Ruhof. Robert, you may begin whenever you're ready.
Thank you very much, Linda. You can hear me okay? I'm assuming you can. So welcome everyone to this webinar presented by OR Today entitled Endoscope Reprocessing, Why the Critical Steps are Critical. My name is Robert Dybec. I will be your presenter today. I first want to thank OR Today for this opportunity to present to all of my nursing and healthcare colleagues out there, and also to the Ruhof Corporation for their sponsorship of this educational activity. So let me start by giving you some information on my background. I am currently the OR Nurse Manager at NYU Long Island Hospital in New York, which is part of the NYU system. There I oversee 5 surgical specialties. I'm also a consultant for the Ruhof Corporation as an educator for not only the Ruhof staff on their behalf at national meetings such as AORN, SGNA, and the Central Sterile meetings. So you may be asking, why is an OR manager speaking about endoscope reprocessing? Well, for many years in the OR, I was in charge of flexible scope reprocessing for urology, ENT, anesthesia, anywhere we were using reusable flexible scopes, where I learned quite a bit about the process required for cleaning and disinfection. So right now we're going to take a look at what we will discuss today. If I can get this slide to move. There we go. All right. So here's our learner objectives for the day. We're going to describe the risks associated with cross-contamination of flexible endoscopes and the identified barriers within the healthcare system that can contribute to this cross-contamination. We'll discuss the current standards, accreditation survey requirements, and professional association recommendations for cleaning and reprocessing flexible endoscopes. We'll describe the key steps required to achieve a clean endoscope and discuss the definitions of cleaning and cleaning verification. And we'll identify technologies that can be implemented in the healthcare setting to support efficient reprocessing, cleanliness validation of endoscopes, and safe patient outcomes. So flexible endoscopes that we utilize every day in various healthcare settings, they're very numerous. By the nature of their design, these critical and semi-critical devices can be very challenging to clean and disinfect before final sterilization or high-level disinfection. This cutaway view of a flexible scope shows some of the inner workings of the scope. But I think you can get a better idea by looking at the photo on the right of a scope that's being disassembled, showing what some of these inner workings look like. There's a lot of wires and optics and channels and things that we will discuss a little more right now. Now take a look at this photo that shows a cutaway section of the tip of a scope, which displays some of the things that may be inside a flexible scope, depending, again, on the type of scope that you're using. Things such as light bundles that will carry the light to the tip, image bundles, or maybe even tiny digital cameras in the tip of the scope for optics, air, water, biopsy channels, suction channels, all surrounded by the bending wires and the outer sheath of the scope. So very intricate, very delicate inner workings wrapped inside that nice, neat package of the outer sheath, which makes the scope look pretty, but a lot going on inside the scope. So some of the critical devices that we see every day in healthcare that fall into this category include flexible scopes, such as flexible cystoscopes in urology and ureteroscopes, bronchoscopes, flexible sigmoidoscopes, duodenoscopes, gastroscopes, most commonly in the GI setting, ENT rhinoscopes, anesthesia intubation scopes, and even speech pathology is using flexible scopes now also. Here's just a couple of examples of the scopes we're talking about. On the top left, there is a flexible cystoscope. In the top middle, you have your flexible ureteroscope. On the right is a flexible rhino or rhinolaryngoscope. You have your gastroscope and your bronchoscope. A flexible sigmoidoscope, a flexible colonoscope, and a gastroscope. And on the lower right is a duodenoscope used for ERCPs, which was really a game changer a few years back in revamping reprocessing standards. We'll discuss that in much more depth very soon about that particular scope. So we did mention earlier about how flexible scopes are extremely challenging to clean and disinfect. Note the distal tip of this flexible scope on the left under normal lighting. On the right side is a photo of a scope after cleaning, but under special fluorescent lighting, which shows residual bioburden left on the scope that might not normally be seen by the naked eye. The takeaway point here is just to remember that just because it looks clean doesn't necessarily mean that it is clean. Now, healthcare-associated infections represent an ongoing serious problem. The estimated number of HAIs in the United States annually is 1.8 million, which is about 1 in every 20 patients. The estimated number of deaths associated with HAIs is around 99,000 every year. In addition, the cost associated with hospital-acquired infections to the United States hospitals is about $40 billion per year. That's money spent in treating nosocomial infections, lawsuits, everything. Now, contaminated flexible endoscopes from the failure to use appropriate cleaning, disinfection, and sterilization processes have been responsible for multiple hospital-acquired outbreaks and serious, sometimes life-threatening infections. Now, the public awareness to the problems related to the improper cleaning of equipment and instruments has been well publicized and also a major focus of the media. This is an event from 2015 out of California that had the nation and the government focusing on the practices of the cleaning and disinfection of flexible scopes. This happened at UCLA Medical Center Ronald Reagan, where they determined that there was a superbug outbreak related to flexible endoscopes that were not cleaned and disinfected properly. So this really changed, as I said earlier, a game changer in having manufacturers revamp their cleaning processes for their flexible scopes. A lot of lawsuits involved with that. Now here's the scope that was the culprit in that whole thing. It's the ERCP duodenoscope. This is the one that was involved in the event in California in 2015. The problem with this scope that they noted was that if you look over on the right here, this elevator mechanism, this is a movable mechanism that is attached on either side. And it moves up and down to allow the passage of guide wires or biopsy devices or brushes, things like that. The problem they discovered was that because it's mounted on either side, it's very difficult to get in there and clean those areas where it's pinned on either side. That's where the contamination they determined was coming from inadequate cleaning. So a lot of manufacturers revamped the design of their scopes and also came out with new guidelines for the cleaning and the reprocessing of the scopes. That also had an impact on other flexible scopes without the elevators with regards to cleaning processes also. So this was a very compelling article from the American Journal of Infection Control from August 2017. Corey Ofsted was the lead author. Corey Ofsted is a well-known name in the arena of infection control and reprocessing. So now we expect that our flexible GI scopes, our colonoscopes, our sigmoidoscopes, they are going to have a lot of bioburden after use, feces, blood, mucus. But look at this study that looked at flexible ureteroscopes being used through the bladder in the ureter in a fluid environment. They don't really get grossly dirty with bioburden after use. But they looked at 16 flexible ureteroscopes after cleaning and after sterilization with hydrogen peroxide gas. All 16 of these scopes, 100%, had residual contamination in the form of either ATP, hemoglobin, protein, or microbial growth. That's pretty compelling information right there, that after cleaning, after sterilization, these scopes still had contamination on them. So what is the future bringing regarding flexible scopes? Well, years ago, this was a trend that was gaining momentum, several years ago, but it's really taken hold much more and in much more areas. And it's the use of disposable or single-use flexible scopes. Here's a couple of examples of these single-use and disposable scopes. On the top left there, you have a digital single-use ureteroscope. My hospital uses these exclusively. You have cystoscopes, flexible cystoscopes, flexible colonoscopes, and more manufacturers are coming out with these scopes. I will share that as a result of infection concerns, cross-contamination, and the inability to really guarantee that our scopes were being cleaned and handled properly, my OR has literally stopped reprocessing reusable scopes and only uses single-use flexible cystoscopes, ureteroscopes, bronchoscopes, and rhinoscopes, as well as intubation scopes. Our GI department, which is extremely busy, is still fully involved in the reprocessing of reusable scopes. But for these other scopes in the OR, we've actually gone to single-use across the board, which reduces our risk for lawsuits, for cross-contamination. The hospital really took that into consideration when they made that decision. So many professional organizations, even the federal government, have put out recommendations, standards, guidelines for cleaning, disinfection, and sterilization of flexible scopes, as well as surgical instruments in the OR. A quick note about the Joint Commission. I've been in the OR for many years, and we did notice a trend in past surveys. We were seeing that there was a huge focus by the Joint Commission on the cleaning and disinfecting processes, with special attention being given to flexible scopes. And that's when my OR was still actually reprocessing reusable scopes. And they were looking for things specific, such as, do you know what the manufacturer's IFUs are for cleaning? What are the steps involved in the cleaning process? So if you're still reprocessing flexible scopes, be sure you can answer these questions that the Joint Commission may have for you when they come by, if they do happen to want to talk about your flexible scope reprocessing. So through all of the recommendations from all of the organizations and manufacturers' IFUs, it became evident that certain steps must be followed and that they are similar in nature. And there are 10 critical steps in the cleaning and reprocessing of flexibles that have been identified. They are point of use or bedside cleaning, leak testing, manual cleaning. You'll see manual cleaning has a little asterisk there. That's because the manual cleaning process alone has numerous subcritical factors involved. Factors such as dilution rates of your enzyme, water temperature, the use of the enzymatics, rinsing, etc. Then you have visual inspection, verification or validation, sterilization and high-level disinfection of your scopes, drying, transport, storage, and documentation. So critical step number one is point of use cleaning, also known as bedside cleaning. This is a pre-cleaning process done before the manual cleaning. Basically, you're taking an enzyme solution, you're wiping down the outside of the scope, you're sucking some of that enzyme solution through any channels, suction channels, any lumens that may be in the scope. You want to get that enzyme solution inside and outside of this scope so that it starts the cleaning process. Now, point of use cleaning immediately after use is probably the most important aspect of reducing the possibility of cross-contamination to other patients. Why? Because this initial immediate cleaning to remove bioburden will prevent the formation of biofilm, which has been associated with cross-contamination to other patients. So just to review quickly, what is bioburden? So according to ANSA and AMY, bioburden is defined as a population of viable microorganisms on an item like a scope or a surgical instrument. It's basically gross contamination. Bioburden can result from contamination by blood, tissue, feces, mucus, and can be found on medical and surgical equipment and instruments after they have been used on patients in surgical and procedural areas. Now, this gross contamination, if left on or inside of instruments for too long and allowed to dry, can allow for the formation of biofilm. So what is biofilm? Well, biofilm is defined as an aggregate of microbes in which cells adhere to each other and or to a surface, producing a distinct architecture. What does that mean exactly? Biofilm can form as a result of bioburden not being removed quickly and efficiently and allowed to start drying. The microbes, the germs, anything that's in the biofilm will adhere to the surface, and it will begin to build a matrix that holds this biofilm together. It kind of builds a community of microbes, and the microbes will then encase themselves under a protective polysaccharide layer. They will develop nutrients to feed the biofilm, which allows them to proliferate. So again, think of germs under a little clear bubble that's being protected, and they're just growing and maturing. So there are 5 distinct stages of biofilm development. So stage 1 is called the initial attachment. That's where the organisms initially adhere to the surface. So if you leave some bioburden on your scope or instrument and it's allowed to dry, that's where the initial attachment happens. The organisms will adhere to the surface and they'll start to develop. Stage 2 is called irreversible attachment. That's where the organisms start to protect themselves under that protective polysaccharide layer. Stages 3 and 4 are the first and second stages of maturation, where the biofilm continues to grow, continues to mature. And stage 5, which is a very interesting stage, it's called the dispersion stage, in which the biofilm will actually open up that polysaccharide layer to release more organisms into the environment that will spread and colonize new surfaces. It's funny, when I talk about this all the time, I think about the spring here in New York, where you get those first couple of warm days, and all of a sudden the termites are coming out of the ground like crazy with wings trying to colonize new areas. But this is what biofilm does. It will grow, it will mature, and then it will look for new areas to colonize. Now, the bacteria that may be growing inside a biofilm under that protective layer is over 1,000 times more resistant to antibiotics than the same bacteria that's not growing in a biofilm. Again, that protective layer will not allow for the antibiotics to penetrate and kill the germs. And that's what this slide is depicting, the protective nature of the biofilm and how the outer layer will not permit antibiotics to penetrate and harm the microbes. Very, very difficult to get rid of. Now, in healthcare, biofilm has been shown to be involved in many infections, such as urinary tract and other catheter-related infections, endocarditis, cystic fibrosis infections, legionellosis or Legionnaire's disease, bone infections, ear infections, tonsillitis, gum disease, and even dental plaque has been associated with biofilm. Biofilm also plays a large role in many of these chronic non-healing wounds that we see in the hospital setting. Again, think about the stages of the biofilm development. You can have an open wound that's dirty. You're going to do a sharp debridement. You're going to irrigate. You're going to flush. You're going to keep it as clean as possible. You're going to give antibiotics. But if you miss a little bit of biofilm and that gets to stage 5 and opens up again, then you're going to start colonizing new areas in that wound, and that wound will not heal. So again, biofilm and chronic non-healing wounds, very, very important. The CDC estimates that over 65% of nosocomial infections are caused by biofilm, which could be bacterial, fungal, or even viral in nature. So step 2 is leak testing. Now, the importance of leak testing cannot be stressed enough. Leak testing is a test where pressure is applied to the internal components of a scope that may reveal an unseen compromise to the scope's integrity. Leak testing can expose a situation where fluid invasion can enter the internal components of the scope, causing damage. Fluid damage literally triggers over half of total endoscope repair costs. Moisture can cause damage as soon as it invades the scope, and the longer the fluid remains undetected and unaddressed, the greater the damage can be to the instrument. Now, SGNA, the Society of Gastroenterology Nurses and Associates, recommends that leak testing be done before the scope is submerged to reduce the risk of fluid invasion. And you must always follow your scope manufacturer's IFUs for leak testing. Again, a pressure test, checking for fluid invasion and compromise to the scope. So why do we leak test? Well, here's a perfect example. Here's a photo of a scope that was disassembled showing the fluid damage internally on a scope that was undetected. The fluid invasion, remember, fluid invasion into a scope, if left undetected, not only can it damage a scope, but if the fluid goes in, it also has the ability to possibly come out at some point, increasing the risk of infecting other patients. Again, cross-contamination. So you want to make sure your scope is secure, its integrity is intact, and there's no leak of fluid going in or going out. Now, step 3 is the manual cleaning process, again with the sub-steps. So the manual cleaning process takes place after bedside cleaning and after leak testing, and is a key step in reducing the risk of cross-contamination. Probably the second most important step. This step will further decrease the bioburden load and reduce the risk of biofilm development. In this one critical step, as we said, there's a variety of parameters that must be adhered to, such as proper dilution rates of your enzymatic solution to water, proper water temperature, effective brushing of lumens. In this one critical step, you have to really be cognizant of all the steps involved with this, and you need to adhere and follow these. Including flushing channels, rinsing, alcohol flush to disperse water. Follow the manufacturer's IFUs for their particular scope and what is recommended. Just a quick note about AERs, automated endoscope reprocessors. These are a really great tool to help us in reprocessing scopes, but the important thing to remember is that the use of AERs does not negate the fact that a point of use and good manual cleaning must be done first. Some newer models of AERs may claim that they eliminate the manual cleaning process, but if the scope manufacturer's IFUs are being followed, the manual cleaning process would still need to be performed. And it's a great idea to make sure you're doing the manual cleaning process, even though you're putting the scope in an AER. All of the guidelines for the manual cleaning of lumens recommends that an assortment of sizes of brushes be available so that adequate cleaning by contact with the inner surfaces is accomplished. You know, scopes come in different sizes, have different size lumens and channels in them. It's important to use the appropriate size brush for these. And you can see a couple of pictures here of different brushes used in scopes. Here's an example of a different technology for the cleaning of lumens and channels. It's called a pull-through device. This device, instead of being pushed through a lumen like a brush, is pulled through. And you can see these silicone discs will contact the entire circular surface of the inner lumen, and pull out any bioburden that may be inside. It's kind of like a squeegee effect, like your windshield wipers, or if you were cleaning windows with a squeegee. Basically, they're rubberized discs that will pull out a lot of the debris and bioburden that may be left inside, and also help clear out some of the water that could be left in there. And they're very effective too. They did some studies on them to show their effectiveness, and compared them to brushes, and they performed very, very well compared to regular brushes. So step 4, visual inspection. One of the most important aspects of cleaning and disinfecting practices is the need to confirm that an item is truly, truly clean. So how can we validate or verify that our manual cleaning has been effective? Well, one way is through visual inspection. Magnifying glasses, illumination devices, as well as specialized telescopes, borescopes that can be inserted into the lumens to inspect for visibly gross contamination. These items are available to help us check for leftover contamination. Here's an example of what actually might be discovered at times when you're using one of these visual inspection scopes. You can see some on the left, there's kind of some debris left inside in a scope. On the right, again, ineffective cleaning of the inside of a scope. I don't know what type of scope it was, but we've actually seen this before in my hospital early on with rigid cystoscopy equipment, where we've discovered when we put the telescope through that there was actually some leftover dirt and grime in there. So again, important to be in touch with your central sterile processing service to make sure that things like that are addressed. So visual inspection may detect obvious issues, but what about the soil we cannot see? So scopes can be cultured. The drawback to this method is the time needed to see results, many times up to 2 or 3 days, waiting to see if some type of growth occurs on the scopes that you've cultured. Scopes are needed really regularly and emergently, and in a busy surgical or endoscopy environment, we simply cannot wait for cultures to come back. I'm sure a lot of us would like to wait for the cultures to come back, but hospitals are busy, endoscopy suites are very, very busy. We really can't be waiting for cultures. They would definitely show you, A, that something's growing, B, exactly what is growing, but again, the time constraints involved with waiting for cultures is just really not feasible. So what about ATP verification? Well, what is ATP? ATP, or adenosine triphosphate, is the universal energy molecule found in all human, animal, plant, bacterial, yeast, and mold cells. This nucleotide is used to transport energy to cells, living cells, that are involved in biochemical processes. The presence of ATP on medical devices or instruments may be an indicator of residual contamination. Now, devices that measure ATP, adenosine triphosphate, again, it's an excellent means of verifying that your cleaning processes have been effective. ATP devices have the ability to test the external surface of anything with the use of a swab, as you see on the right there. Some devices actually have the capability of testing the inner lumens of scopes and other cannulated instruments with the use of a test sponge, as shown here. You'll see a test sponge going inside of a flexible scope. And that test sponge can actually be used to test ATP inside the lumens of the scope. Now, understand that devices that fail the ATP test will need to be re-cleaned and retested before final high-level disinfection and sterilization. So the presence of ATP is an indicator of residual contamination. Granted, we don't know what that contamination is. We're not culturing, so we don't know what's growing. It's just telling us that there's something there that shouldn't be there. Cleaning to eliminate or reduce ATP means the reduction of organisms that may contribute to healthcare-associated infections. Again, the ATP measurement, it's an excellent means of verifying that your cleaning processes have been effective. So if you have a scope that was just cleaned, and it's done it with the cleaning process, and you test it for ATP and you come up with a higher value than is acceptable, again, that scope would need to be cleaned again and retested to make sure that it's had a good cleaning process before sterilization or high-level disinfection. So what are some of the benefits of ATP testing? Well, again, it's a confirmation of the cleanliness of your medical devices. You're thereby reducing the risk of cross-contamination between patients. You also have the ability to track and monitor your cleaning practices. So the devices can actually hook up to your computer, and you can actually track and monitor cleaning practices. For instance, it can be set for individual scopes, like scope number 1, 2, 3, 4. You may discover that, hey, all of a sudden scope 4 is failing more than the other 3 scopes. Well, maybe there's some sort of compromise with scope number 4. Maybe you have John and Jane who are cleaning the scopes, and you notice that for some reason, John's having more positive ATP tests than Jane. Maybe that's somebody who needs to be re-educated. Again, auditing also very important in scope cleaning and verification. Also with ATP, it's a quantitative assessment. You get a number used for documentation, and above all, it's a quick and easy test. Unlike cultures, which could take 2 or 3 days, an ATP test takes as little as 15 seconds to get a result. So sterilization and high-level disinfection would be the next step in reprocessing. You've cleaned your scope, and say you've tested it with ATP, you got a really good clean scope. Now you're going to send it out for your sterilization or high-level disinfection, depending on what your hospital or institution uses. This prepares the scope basically for use on the next patient. The type of sterilization, the type of high-level disinfection is totally dependent on the methods available at your facility, the type of scope, obviously, and also the scope manufacturer's validated processes for sterilization and high-level disinfection. So not all scopes can be sterilized. Some of the things that we use for cleaning, sterilization, disinfection: Sterad, Sterad NX, Sterad 100, peroxyacetic acid, ethylene oxide gas, plasma gas, glutaraldehyde, OPA, hydrogen peroxide. And again, the manufacturer of the scopes must validate these sterilization or high-level disinfection practices. If they say it cannot go into ETO gas, it cannot go into ETO gas. They will tell you what their validated, recommended practices are for sterilization and high-level disinfection. So an alcohol flush in drying will displace residual water and also aids in drying the channels of the scope. It displaces that water. Manual drying on the outside should be done with a clean, lint-free cloth or gauze. That's right from the recommendations. And for scopes that will hang in drying cabinets, make sure you're following the policies and procedures established by your institution, by the scope manufacturer, as well as the cabinet manufacturer. Now, with transportation guidelines, the transportation guidelines of scope states that the container used to transport must be rigid, must be puncture-proof, and you must clearly be able to see if the contents are clean or contaminated. Here's a couple of examples here where you can have the disposable box where you transport your clean scope. When it's contaminated, you flip the cover over and it'll say that it's a soiled scope. Again, specific guidelines in the recommendations for what your transport containers should be and how to transport. Again, following your policies, following the manufacturer's guidelines. So some of the current standards for scope storage, well, we do have storage cabinets, which sometimes can be the drying cabinets also. For scopes like GI endoscopes, this is what they typically do. They'll hang these to dry. They'll hang them for storage in a secured cabinet. Very important to follow guidelines for touching. So basically, as these scopes hang, most of the manufacturers of the cabinets and the scopes say that the tips of these scopes, which are going into the patient, should not touch each other if you're hanging them side by side, should not touch the bottom of the cabinet, and should not touch the sides of the cabinet. Many companies have come out with these tip protectors to keep them from actually touching the walls or the base or the tips of other scopes. So storage, again, very, very important. So documentation, let's just elaborate on this a little bit. You need to have accurate documentation of your scope use, your scope cleaning, and your disinfection. This is required for accreditation and compliance. You want to have traceability. This is the big problem that came out of 2015 in California, where they started to try to find out, well, how do you know which scope was used on which patient? So you need that tracking ability, you need that traceability. And now it's come full circle where you want to be able to follow that scope from patient use to cleaning to decontamination to the next patient, and which scope was it, which accessories were used with it, and who was it used on. In the event that all of a sudden they get an issue with cross-contamination, you'll be able to determine exactly where that scope was at all times, who was responsible for cleaning. Again, traceability. You want that traceability, and you want to be auditing these things also. You want to audit the use of these scopes for documentation purposes. Joint Commission requires this for tracking, and you have to have this available. So just to summarize, we described the risks associated with cross-contamination of flexible endoscopes. We identified some of the contributing factors. We discussed the current standards and recommendations for cleaning and reprocessing flexible endoscopes. We described the key critical steps required to achieve clean endoscopes. And we even identified some technologies that can be implemented to support efficient reprocessing. So at this point, we're going to open up to some questions. I think we'll have enough time, but if there's a lot of questions, I think Linda will inform you of how we can answer questions if we don't get to yours.
Yep, I will do. Let's start off with why, with all that we have learned about the issues surrounding improper cleaning and disinfection, is there still a problem?
Is there still a problem? Well, if there wasn't a problem, we wouldn't be having this webinar right now. Pretty much, you know what happened with the 2015 event in California that changed a lot of things. Most of the endoscopy suites, most of the GI centers, they have become compliant with the traceability, with the cleaning processes, with all of that. Where we still see issues, though, is in outside areas such as doctors' offices, where they use reusable scopes, such as urology offices with reusable flexible cystoscopes, ENT offices where they're using reusable scopes. These are areas where if you don't have a dedicated person to cleaning, reprocessing, and making sure you're following the manufacturer's IFUs and good guidelines, a lot of falling short comes about with these areas. You know, there's quick turnover. Whoever the staff is doing this, or were they properly trained? Are they auditing the practices? There's many times the cleaning practices. You know, there's so many areas in the 10 steps where you can actually just cut corners and save time. You know, complacency. You know, you really want to audit the processes and look for opportunities to improve. The last thing you want to do is be contaminating patients, especially in the office setting. I did have a call probably last year from a urology office where they were inquiring as to what our single-use scopes were, and they were looking into going that way to see if they could make that work for them, because I guess they were having issues with, again, possibly the reprocessing of the scopes and not being able to guarantee that they were doing the right thing. So hope that answered the question. Still a problem. Big problem, maybe not, but still a problem out there.
Okie dokie. So what is your recommendation for the best enzymatic cleaning solution to use for the cleaning step?
Oh, okay. Well, first and foremost, I'm not a chemist. Secondly, I'm not a salesman. I don't sell these products. All I could really say is if you're considering enzymatics or which ones you have, changing the ones you have, go by what's in the literature as far as suggested what a good enzyme solution should have, such as it needs to be multi-tiered. You'll see that term multi-tiered on a lot of enzyme solutions. Multi-tiered just simply means that there's different types of enzymes that will attack different types of products, like fat solubles, protease, you know, carbohydrates, things like that. So a multi-tiered will contain a variety of enzymes that will address all forms of, you know, bioburden or that could be left on your instruments or scopes. They should be low sudsing. You don't want them like bubbling up like a bubble bath. Temperature has become a big issue with some of these. You want them to be adaptable to different temperatures. You know, early enzymatics, you know, you had to measure the water temperature. It had to be exactly at a specific temperature, but some of the newer ones are temperature adaptable, so they can work in a variety of temperature situations. They need to be free rinsing. That basically says that there'll be no residual enzymatic on the devices once you rinse them. They'll be free rinsing, nothing left over. They need to have clearly a neutral pH. You don't want them damaging your scopes. Non-abrasive, you don't want them damaging your scopes. And most of them are biodegradable now. So these are, I guess, just the things you need to look for from the enzymatic manufacturers to see if this is what they contain. And those are good suggestions from SG&A, from the gastroenterology physicians. Again, related to all of their cleaning practices and recommendations.
Okay, so if single-use scopes eliminate many of the problems, why isn't everyone just using them?
Well, first and foremost, they are not cheap. Okay, so as I described in the scenario where the urology office was calling, their biggest concern was how much these scopes cost. If we were to switch over to them, what are they going to cost us per procedure? How much are they getting reimbursed for a procedure? Larger organizations like mine, big hospital systems, big hospital networks, they justify the expense when they kind of like weigh the analysis of if we could possibly cross-contaminate or injure a patient, what is a lawsuit going to cost? What is the treatment of a hospital-acquired infection going to cost? What is the bad press going to cost us? Could we possibly lose our accreditation because we didn't do the right thing? So big organizations, they will justify that expense to reduce those risks. It's a risk reduction. But again, the doctor's offices, they many times simply cannot afford them based on the procedure reimbursement. So that's the biggest thing. It's that they are not cheap. They're definitely not cheap. And the other issue I think that some people consider, probably not enough people, is that this is a disposal issue also, where you're filling landfills with more and more plastics, more and more things that are only used once. Maybe there'll be a time where some of these scope manufacturers will take them back for reprocessing or reuse or something like that, which would be beneficial. But right now you're increasing the load on the environment by using the single use also.
Okay, I've got a couple of questions about ATP testing. Is it recommended that ATP testing be done on every scope every time? And should the testing be done after manual cleaning and prior to HLD or after HLD?
Okay, so good questions. So last time I checked, there really was no current standard set by any organization, any accrediting body that when ATP or how much ATP testing should be done. I lecture that basically it's up to the individual organization, the institution, the hospital to set up a policy of when they want the ATP test. I was told once at a meeting several years ago that one of the VA hospitals was literally testing every scope every time with ATP to see if they were clean. Other hospitals will set up a process where they will test, one scope a day. They'll test scopes, once a week, kind of do a random selection type of thing just to check on things. But right now, there's no current recommendation set by anybody that says you need to check every 5 scopes or every scope or anything like that. Again, policies need to be set up by the organization. With regards to when the ATP testing should occur, I did hear of a hospital that was doing ATP testing after bedside cleaning, manual cleaning, and high-level disinfection. The problem with that is if you're testing a scope that's supposedly patient ready for patient use, you are now contaminating by doing the ATP test, and then you would have to reprocess it all over again. So there's your answer right there, is that the ATP test is a test for your cleaning process, not your sterilization or high-level disinfection. So you do your bedside cleaning, your point of use cleaning, you do your manual cleaning, your drying, you can test it at that point to see if you did a good job. If you did a good job and you've tested it, rerun it again, send it for high-level disinfection. If it didn't come back good, you're going to want to manually clean that scope entirely again, test it again before sending it out for your sterilization and high-level disinfection.
Okay, and a different question here. In your OR, who is responsible for doing the point of use cleaning of the scope at the bedside?
So that would be the responsibility. Well, again, I'm going to tell you how it used to be, because right now we do not use any, literally any, reusable scopes. But at the time we were doing it, it would be the surgical tech or the scrub nurse in the room would be immediately responsible. The only thing we use now where there is a point of use cleaning in the OR are the TEE probes, which is done by our perfusion techs. Again, they are responsible. They're right in the room when they're doing the TEEs. Again, it's not a scope. There's no lumens, but those probes also require point of use cleaning. So in our OR, when we were using the reusable flexible scopes, it was the surgical tech who was scrubbed or the OR nurse that was acting as the scrub nurse to do that point of use cleaning and immediately get it out to the manual cleaning, which would be done by somebody else. Hope that helps.
Okay, and another scope question. What are the scope drying requirements?
Scope drying, again, you're going to have to go by manufacturer's IFUs. And if you're using a cabinet for drying, then you're going to follow the cabinet manufacturer's recommendations also. Some of them have circulated filter air going through them. Again, that's all based on manufacturers. And the drying should be part of the MIFUs by the scope manufacturer for the entire cleaning process. They're going to tell you, we want you to do this at the point of use bedside cleaning. This is our manual steps. These are our drying steps. These are our transport steps. This is the storage or drying steps. So again, following the manufacturer's IFUs. They're all pretty much the same based on the manufacturers, but you have to specifically look at your manufacturer and your model of scope to answer that question.
Okay, can you discuss drying cabinets, required versus recommended?
Drying?
Drying cabinets.
I'm sorry, Linda, you cut out. Oh, drying cabinets.
Drying cabinets, yeah.
To be honest with you, not really, because we never use them in the OR. That is, I know that the one they have down in our endoscopy suite is enormous. I think they have 72 scopes that they hang and dry. So I don't know a lot about the drying cabinets, except that they are very widely used and also very widely recommended by scope manufacturers because of the way they will store the scopes, allow them to dry, and keep them safe from damage.
Okay, now how have you traced accessories used with the scopes? For example, instrument used for BAL with scope?
Getting out of my realm here, I think you're talking endoscopy, but I know that the trend that started years ago, even pre, is that to start using single-use disposable accessories for your reusable scopes. Prior to that, that's when the recommendation came out to keep the accessories, the channels, the caps and things like that with the scope at all times. They'd come up with those little baskets where you would hang it on the scope, and it would follow the scope through the entire process from start to finish, so that there was that tracing, trackability of the accessories. Where are they at today? I'm not sure. I know that our GI suite has pretty much gone to disposable accessories for the scopes. But other than that, I mean, there are devices out there that will act as like a little tea strainer that attaches to your scope that keeps the accessories with the scope throughout the entire process, so that they don't leave the scope side and goes through the same exact process, and thereby you have the tracking and the traceability of the accessories.
Okay, another question here is, if we have transitioned to disposable tip ERCP scopes, do we need to continue to culture the scopes?
Again, there's a policy question for your hospital. I've heard about these tips for the ERCP scopes, and I don't know how effective they are. You guess you can't go wrong culturing, but I really don't know the answer to that. That would have to be a policy decision by the organization on whether or not you need to continue to do that. And also, I would look at the recommendations from the Gastroenterology Nurses Association, as well as the physicians, AGE, Association of Gastroenterologists, and what their recommendations are on these, because that was, again, and continues to be a hot topic, those ERCP duodenoscopes. So what the latest is, I can't really speak to, but there are resources out there that you can definitely get more information about, either what's being done, what should be done, or at least aid you in developing a policy for that. That's where I would go.
Okay, another question here is it possible to use 70% IPA for drying all kinds of scopes?
70%, I guess IPA is isopropyl alcohol. That's pretty much what we were using at the time, because that's what was provided in the OR. I never heard that there was a contraindication to that. Don't know why the question is being asked, to be honest with you, but we always used the 70% alcohol, which was, that was commonplace in the OR. That's what we used to use. Be interesting to see if that's changed at all, because I know that they do make other concentrations of the isopropyl alcohol, the 90%, and I'm not sure where that comes from. Again, the alcohol flush was really to aid in drying. Again, alcohol will kill some things, but that was not its intended purpose for flushing channels. It was to aid in the drying and elimination of water on the external surfaces, as well as the internal lumens. Again, flushing that alcohol through, and then blowing air through with a dry syringe to get any residual alcohol out, or to dry the alcohol that might have been left in there. So I don't see a problem with 70, because that's what we used to use, but be curious to see if that's changed at all.
Okie dokie. Do you still use ATP for a broken scope sending out for repair?
We did not. Any broken scopes sent out for repair were kind of like cleaned and decontaminated as best as we could, and sent out to the manufacturer for repair. We didn't test them. Wasn't required by the manufacturer, so we did not test for broken scopes.
Okay, another question here. How did you get buy-in to convert to all disposables?
Well, I will say that I had a lot to do with that, because of the ineffectiveness that was being observed with who was responsible for doing the cleaning and manual cleaning of the scopes and reprocessing of the scopes. And because there were too many hands involved, where the anesthesia techs, well, we're going to do our intubation scopes, but who's going to do the urology flexible cystoscopes? Who's going to do the urology flexible ureteroscopes? You don't have a point person 24/7 there to do those scopes in the OR. And our endoscopy suite would not reprocess any flexible scopes used in the OR, so it was really our responsibility to do that. So when we realized that there was really no traceability, we couldn't guarantee that they were being done right. How do we know somebody's not cutting corners? How do we know we're not auditing? There's no traceability. And when we realized that this could be a really big potential problem for the organization, it was addressed. We contacted some vendors. We looked at what we had to do, and our first transition was to flexible ureteroscopes, which they're relatively expensive, and we are a very big urology hospital doing a lot of stone work. So first flexible ureteroscopes, then we went to flexible cystoscopes, and then eventually to bronchoscopes and rhinoscopes for use with anesthesia and for cardiac when you're doing lung cases. And really, there was not a lot of pushback based on that, because when you factor in also what a reusable scope costs, those are very expensive also, what repair costs cost on those breaking down, and they broke relatively frequently. I mean, there was a certain lifespan associated with those reusable scopes, and excuse me, and you have to be able to send them out for repairs, which are again also very costly. So when you weigh that, with the fact that now you're reducing the total risk of cross-contamination, the total risk of causing an infection, bad press, all those things that were mentioned earlier, it kind of like, paid for itself in a sense. Less worries about, opening a scope. Was this cleaned properly? Nope, you're opening a single-use scope. It's clean, it's sterile, guaranteed. No worries about that at all. No risk of cross-contamination, and a sterile scope every time. So luckily for our institution, it wasn't we weren't up against the wall trying to push it through. It actually worked out very well for us, and it's been a blessing, to be honest with you. I mean, it's expensive, but it's been a blessing being able to not have those worries again. So that's where we're at. Hopefully, if you're considering that, your institution will push through it also.
Okay, we've got time for one more question, Robert. It's is the ATP testing tool available to buy commercially, or do you have to go through a certain company?
Well, I guess that would be a question for Ruhof. I don't know. I don't know if what the sales are on those particular items, but I know that Ruhof does have an ATP device, which is the one that we use in my hospital. So that's a question for Ruhof.
Yes, and as you can see on the last slide, Ruhof's website address is there, so please visit them for further questions. We have got further questions, Robert, but as we are nearly out of time, so I will send them to you afterwards and you can answer them offline and at your own convenience. So
Absolutely.
At that point, Robert, I'd like to say thank you. Thank you so much for your time today and for a really great and informative presentation. As mentioned before, please visit today's sponsor's website, ruhof.com, to learn more about the products they provide to our industry. As promised, the answer to today's trivia question is New York City. So congratulations to our winner, Cynthia Thomas. Enjoy your lunch bag. A quick reminder, you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your certificate, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Please visit OR Today Webinars Live for details of all our upcoming webinars and complimentary registration. So thank you once again for your time, everyone. And we'd like to wish you happy Perioperative Nurses Week and also happy Thanksgiving from everyone at OR Today and MD Publishing. Thank you so much. See you again soon and enjoy the rest of your day.
And thank you, everybody, and stay safe out there.